I would occasionally get patients who had seen one or two other practitioners who had been trained in this work but hadn't had success. And when you would dig in with more organization of the data, you would recognize where something that needed attention hadn't been attended to yet. And so it just came back to, right, like we need a system of monitoring what we need to be looking at. Have we looked at it? Have we improved it? Have we then optimized it? Because that's the process that gets people to the other side of this disease.
Welcome to the MindHealth360 Show. I'm Kirkland Newman, and if you, your loved ones, or clients suffer from mental health issues such as depression, anxiety, insomnia, poor memory, poor attention, mood swings, exhaustion, etc., I interview the leading integrative mental health practitioners from around the world to help you understand the root causes of these symptoms, many of which may surprise you and suggest solutions to help you heal. If you like this interview, please do subscribe and forward to others who might find it helpful. If you want further information, please go to www.mindhealth360.com or find us on social media. So Dr. Kristine Burke, welcome to the MindHealth360 Show. I'm really thrilled to have you here. And you're one of the sort of pioneers in functional medicine for a whole range of issues from, cardiology, stroke, heart problems, diabetes, dementia, cognitive decline, mold illness. I mean, you name it. You have a very, very wide spectrum of conditions that you treat, and a very wide toolbox of tools that you use to treat those. So you have quite a unique approach in the sense that you're incredibly comprehensive, I feel, in the work that you do with your patients. You run a clinical practice, but you also run training programs for practitioners. And I think, you're obviously very, very busy. So before diving in, I'll just introduce you and give a little bit of background about you. You're a triple board certified precision medicine physician, entrepreneur, author, educator, and researcher. You're an expert in the reversal and prevention of chronic diseases such as dementia, diabetes, heart attacks, strokes, with a special focus on mold-related illness and its connection to many health conditions. You co-founded TruNeura with its unique AI-supported patient coaching interface and provider-focused clinical decision support software. And I think that's really interesting because, with that, you're addressing the pain points both of the patients and also of providers. And we know that functional medicine can be challenging for both in terms of the overwhelming amounts of information that it requires us to process, both as patients and as practitioners. You have done this to advance the mission to scale the prevention and reversal specifically of cognitive decline worldwide. And to further your mission, you teach precision and functional medicine to advance the knowledge of other physicians and practitioners in your role as assistant clinical professor of preventative medicine at Loma Linda University School of Medicine, which I always think, Loma Linda being one of the blue zones, as we know. And as an educator and frequent speaker for a variety of national and international organizations, you're also the founder and chief executive and medical director of True Health Center for Precision Medicine in Northern California, which is a multidisciplinary practice that delivers personalized primary care with a proprietary data-driven wellness plan that successfully prevented any heart attacks from occurring among their members' patients for over a decade. Now, that's pretty wonderful. And, and you talk about root cause medicine and reversing chronic illness to help people reclaim their health and their hope. So you're very mission driven and you are very data driven. And I think those are two very important points. And you're mission driven, obviously, to really reverse complex chronic illness in all its forms. And you're data driven in the sense that you seem to be harnessing the vast amounts of data through your AI tools to help you do this. So you're busy.
Yes.
So I guess my first question, Christine, is tell me a little bit about how you got into functional medicine. I mean, you're a sports doctor, you're a family care provider, you have a lot of, sort of trainings and awards and under your belt. Tell me a little bit about your career and what's brought you to this point.
Yeah, so I I started off my career in private family medicine and I ended up in family medicine. I had planned on being a surgeon, actually an orthopedic surgeon, commensurate with my sports medicine background. And then once I got into my training and every clinical rotation, delivering babies, I'm like, well, I don't want to not do this again in my career. And then, doing ENT and doing, this, that, and the other thing, everything I just loved all of the variation. And so anyway, that landed me into family medicine where I could have my hands in a little bit of everything, which, as you listed out, has kind of been the theme of my career. But I ended up with a very large practice, one of the largest private family medicine practices in our area. And we were, taking, I thought, great care of our patients, following all the guidelines, following the algorithms, using all of the appropriate medications where they were indicated. But what I noticed after about 15 to 17 years of doing that is that we were kind of just managing our patients' decline. Like one blood pressure medicine became two, two became three over time, right? Cholesterol medications layered in, and still people were having, negative health outcomes. And so I just started feeling restless with that and like there had to be a better way. And it just so happened that at about that point in my career was when the Women's Health Initiative study came out about hormones and risk of hormones. And I had been saying what I had been told, that bioidentical hormones, there wasn't any data, and that there was no evidence that just because it was natural, that it was safe, or all the things that I had been taught in my training. But that was about the same time as kind of the Suzanne Summers craze of bioidentical hormones. And that was just starting to get going. And so I had wonderful relationships with my patients. So they would very politely say, okay. And then they would go off and they would do it anyway with someone else who was doing it. And then what I noticed was as they started coming back in for their routine follow-ups, like this group of women looked amazing, felt amazing. And the women that I was managing the way I had been taught didn't have that same vitality. And so that just started making me question, like, my own paradigms. Like, is what I know really the best? Is there something else? Is there more to this? Should I know more about this? So I started investigating that. And that journey into bioidentical hormones is what led me into functional medicine and understanding the root cause approach. Because I happened to be at a conference, and sitting next to me at lunch was this doctor who, to me at the time, just seemed full of all this root cause wisdom. And so I asked him, I'm like, where do I go to learn what you know? And then he sent me to the Institute for Functional Medicine. So as I started learning that, I had been pretty interested in cardiovascular prevention, because when you're working in primary care, cardiovascular disease is what kills half of us. And so it's a pretty big part of your management. And so I had an interest in that. So I was working in the bioidentical hormones, trying to improve health and vitality. And then I was working on cardiovascular disease prevention. And that's, as you mentioned, kind of how this data-driven wellness plan evolved, is gathering more data. What makes a difference? What are the things that we really need to be looking at, that when we monitor and manage them, specifically the inputs of vascular inflammation, can we make a difference in the number of events we see? And as you said, we can very, very importantly, we can make a huge difference, because over that period of time, it was about 12 years before we had even a single heart attack happen in our practice. There should have been, based on the number of patients that we had and the age of the patients that we were taking care of, many in, from mid 40s to mid 80s, we should have seen probably statistically about 6 heart attacks in that time frame. And so then now you start feeling a little bit empowered, like, yes, focusing on these things makes a difference in outcomes. And then that's when I became aware. Well, first, during all of that time, I had three family members that had been affected by Alzheimer's disease and passed from that disease. And as most people do, you feel very helpless. There's just nothing really that you could do, and you just watch this really awful decline. And so when I started seeing the correlation between the focus on vascular health and then on metabolic health, because metabolic health, blood sugar regulation, diabetes, reversal of diabetes, they're all really interconnected. So while it sounds like I have this super broad breadth at the core, they are each related to each other. And that's really how it kind of unfolded. And so we started seeing that with our focus in these areas that we had better cognitive outcomes. Like we had less cognitive decline among our patients than you would expect. Not statistically analyzed. This is just our perspective, our perception. And so then when I learned about precision medicine work for cognitive decline, I really wanted to dig into that. And there was so much overlap with that. And then the work that I had started doing with the complex chronic illness and biotoxin illness, specifically mostly around mold, because there was so much cognitive impairment in people who had had exposure to mold, that overlap was really apparent. So that's the long story of kind of how it all unfolded and how I ended up where I am.
It makes so much sense though, because, ultimately it's a systems-based approach, right? And so I think the beauty of family practice is that you really have, or as in England, where I'm based, we call general practice, so GPs, is that you really have this sort of wide lens, wide angle lens on all the systems that are affected in the body, how they interrelate. And really, I mean, you're practicing medicine the way it should be, which is from a systems-based approach, looking at the functionality of all the organs as they interconnect. I mean, you can't subdivide, and yet our medical model does subdivide into these silos. And I think that's been part of the problem with the medical approach to date, has been this sort of siloed approach. So I think, you obviously have had exposure to all these different systems, and that's how you approach things. And so did you move into sort of focusing? Now, I know you have several areas of focus, but with TruNeura, so tell me a little bit about that, because, I think at the moment everybody's watching closely AI and how AI can impact, health, how they can impact, practitioners working with patients, how it can impact patients. But we're sort of at the new frontier of it. And there are very few people who are managing to do it in a way that really seems to be working. And it seems to me that you've developed something with TruNeura that is harnessing the capacity of AI in quite an effective way. And so I guess my first question is, tell us a little bit about TruNeura and how you came to develop it and what it is. And second of all, was it because of your personal experience with your family members with dementia that you chose to move into that? Or is there something about Alzheimer's and dementia that lends itself particularly well to both the functional medicine approach and the AI data crunching approach?
Yeah, those are such great questions. And I think there is a little bit of all of that is involved. So TruNeura really was the genesis of it really came from my pain of trying to manage the massive amounts of data that we try to utilize in this precision medicine approach, how challenging it was for my team to manage, and then how difficult it was to train new practitioners to be able to come in and operate at the level that we wanted to be able to perform at. So it just started with, well, first of all, I love organizing things. I'm kind of an operations person, and I like figuring out how to make something more efficient within our practice. It's just that's something that I enjoy, which lended itself very well to this particular problem because in cognitive decline, it's really the kind of the highest level of complexity that we work with patients, in part not so much because the things we need to pay attention to are different. Really, all of those different subsets of root cause apply in so many health conditions, but because it's a fatal disease and time is brain. So the pressure to compress the how quickly and how much of that data we address is different in cognitive decline than it is in other things where we have a little bit more leisure of time to work through things. So because there was all of this data that we wanted to understand about, people's metabolism and their inflammatory markers and what was going on in their vascular health, because vascular health is a key to brain health. What was going on with their hormone balance? How were their nutrient balances? And then what was the load of toxins that were being carried by that person's body? Because those are the things that we have to sort through to bring the body and the brain to a place where healing can occur. And that's really what I feel like we're doing. But when you take all of that data, and at least at first, because it's been almost 10 years now that I've been doing this work, it was just like, all these PDFs on my desk, all these printouts of different labs, and then trying to sort through it and recognize patterns and figure out our treatment course, and then trying to organize that in a way that we could follow it over time so that we could see what changes were happening, what were the effects of our interventions, were we moving in the right direction? So that, kind of begat, one spreadsheet that was tracking the labs. And then we realized that there were different ways that we needed to use that data. So we created integrations, one that would organize the data in a way that we could use in our medical note, one that would organize the data in a way that we could track it over time, and then one that would organize it in a way, in a PowerPoint actually, that we could use to present the data to the patient and their family, because that is also an overwhelming process. So trying to put it together in a way that could be that you're taking all of this huge amount of information and making it so that it's understandable. Like, obviously, they're not going to understand all the nuance of every single marker, but putting it so that they can at least understand the story that you're trying to tell about why paying attention to all of these things is so important to improving the cognitive health of their loved one. So that was kind of the initial genesis of it. And then, of course, trying to track all of the data around the lifestyle changes that the patient is supposed to make, because that's how I look at this. There's two sides to this partnership. There are all of these lifestyle changes that we need our patients to make to create the environment for the brain to heal. That's on the patient side. Sometimes the family members, depending on how impacted cognitively the patient may be. And then on the clinical side, we have all the data that we need to manage and follow and adjust. So it just kind of became natural for those things to come together within TruNeura so that we could utilize wearable data to understand how effectively our patients were implementing the things that we were asking them to do. Were they actually sleeping better? Were they sleeping longer? Were they getting their activity, right? How were they doing their mindfulness practice? And we could see that in their heart rate variability. So having that information so that we knew how that side of the equation was going, and then being able to track the labs in a consistent format, both in a way that is easy to deliver to the patient so that we could see it that way. So we developed this, or we utilized this scoring system that allows the each marker or section of markers to be graded on a scale from 0 to 100, because everybody is familiar with getting 100% on their test. That's a metric that makes sense to people, because it's so hard when you're trying to explain results to a family, because this particular item is better if it's lower. This one is better if it's higher. This one is better if it's at the higher end of normal, but it's not alarming if it's outside the range, right? Like there's just all these rules that we understand as practitioners who do this work and deal with this data every day, but is so confusing for families to look at, right? But if you're just looking at how am I doing on a scale of 0 to 100, like that people get.
Yeah.
And so it just makes it a lot easier. And then we can peel down or dial down into the data at whatever level of detail is appropriate for discussion, whether it's a discussion with the family at a higher level or a medium level, depending on how much they want to dig into it, or it's in our own internal clinical discussions. Then we can also see the data in a pattern where the same markers always occur in the same order, because recognizing those patterns is really what helps you to see where the preponderance of imbalance is for any one particular patient. And so, people will often say, oh, you're a protocol. No, no, this is not a protocol. This is just a process of applying this systems biology work. And the process helps you to be more effective, because it's really easy to lose the forest for the trees, to not to not recognize something, or to miss it because it's lost in this sea of data. So all of that organization, I think, just helps us to stay on track and be able to focus on the things that make the biggest difference.
Yeah, I mean, that's amazing. And in terms of the lifestyle factors, like you mentioned, heart rate variability and sleep, etc., do you work with wearables to then feed in that data? Okay. And
Yeah.
presumably, so whatever wearables the patient happens to have, whether it's an Oura ring or a sort of Garmin watch or some sort of tracker.
Right. So we integrate with a wide number of wearables. Pretty much anything that already integrates with Apple Health or Google Health
Yeah.
is integratable within our system. And then there are also a number of other different wearables that we can also integrate with. So it's really useful.
And then presumably you also integrate with all the labs, or so you basically, all the different lab tests, or do you have your preferred ones that you then prioritize and recommend?
Yeah, that is always a work in progress in technology, isn't it? So we have a PDF reader that has been highly trained on reading the specific labs that we're starting with. So I took, from my experience in the work that we've been doing, what I thought were the essential things that needed to be addressed for us to be able to see improvement in cognitive decline. And so that's our base platform.
Yeah.
And then I already have, 3 lists, level 2 priorities, level 3 priorities of things that I want to bring in to expand that may be needed by certain people, but maybe not by other people. But I really wanted to focus on how do we make this something that more clinicians can be adept at? Because that's one of the things that we've seen, is that this work is hard. It's very, right, like it's very data heavy. There's a lot of work that's done outside of the direct clinical encounter. And so many practitioners who have been trained in how to do this type of work don't continue doing it because it's hard. It's really a lot of effort. And so I wanted a way of making it more manageable, because we have this exploding problem of cognitive decline. Like right now in the US, we have about 6 million people with Alzheimer's or with diagnosed dementia, but there are about 20 million people, more than 3 times that many, who have cognitive impairment. So
Mm.
not at a level where they're diagnosed with dementia yet, but they have cognitive impairment. So we need an army of practitioners who can do this work and not just learn this work, but be able to implement it and be successful with patients. One of the other things that kind of led into wanting to bring TruNeura to market is that I would occasionally get patients who had seen one or two other practitioners who had been trained in this work but hadn't had success. And when you would dig in with more organization of the data, you would recognize where something that needed attention hadn't been attended to yet. And so it just came back to, right, like we need a system of monitoring what we need to be looking at. Have we looked at it? Have we improved it? Have we then optimized it? Because that's the process that gets people to the other side of this disease.
100%. And I mean, we know that it's sort of small lifestyle changes or large lifestyle changes, but that are consistent and that happen on a daily basis. And I think especially for patients, especially if patients have cognitive decline or, even mild cognitive impairment, it's challenging, and even if they have help, I mean, even people who have, maybe a bit of anxiety, a bit of depression, it's hard. Functional medicine can be very, very overwhelming. And so it sounds to me as if you're offering both, the practitioners a way of organizing and making sure that they've ticked all the boxes and they've covered all their bases, but also patients a way of then processing and simplifying what they need to do so that everybody's sort of very clear about it. And you talk about your sort of the key principles that you want to focus on, and there's level 1, level 2, level 3. What would you say are the key principles that you focus on when it comes to cognitive decline? Like, what are the sort of low-hanging fruit that you look at first?
Yeah, so I think that that's one of the things that's really key to this is that at least in the state of our understanding and the state of the research so far, we can't really go at this in a very stepwise approach. There's a base that's really broad and requires a lot of data that we pretty much need to do on everyone. And then from there, we can take some more nuances to that point. The initial things that we need to look at in everyone, we need to look at their metabolism, what's going on with their blood sugar regulation, because we know that the brain can't control the amount of glucose that enters the brain. So if the body blood sugar is too high, the brain's blood sugar is too high, that over time creates an insulin resistance within the brain, which means that the brain then can't utilize or make energy ATP efficiently. So without ATP, then, right, all the normal processes of the brain aren't happening. And then on top of that, generally, this is a brain that has excess inflammation, that has excess toxin burden, that may have, more microbes than should be present, like especially from the oral microbiome or some of the chronic stealth infections that we find when we do autopsies on Alzheimer's brains. So there's that whole wide array of things. So starting with the metabolism, because you have to have energy to repair. Then looking at the nutrients and the mitochondrial functional markers. So that goes along with the first part, but specifically making sure that we have the nutrients that are available, for example, that are cofactors to certain enzyme reactions that help us with oxidation, like superoxide dismutase needs to have manganese and zinc and copper for it to work properly. So making sure all of those nutrient levels are optimized and not just at the traditional medical levels of not super deficient so that you have a disease related to that deficiency, because that's the other big difference, right?
Yeah. Yeah.
Is that we are looking at trying to get things into an optimal zone because we need to optimize the functional processes. So it's different than deficiency or excess, where you're looking at where does this cause a specific disease to that nutrient. So that's a little bit different as well. Then we want to look at hormonal balance. So hormones have a very important impact on brain health. We know that the same areas in the brain that tend to atrophy the most in Alzheimer's disease, because Alzheimer's is the most common type of dementia. About 70% of dementia is Alzheimer's, which is why I keep referencing that. So we know that those areas that atrophy the most are also the same areas with the highest estrogen receptor density. So one of the hypotheses for why there are twice as many women with Alzheimer's disease than there are men with Alzheimer's disease is related to this difference in the hormonal availability, because men also have estrogen in their system, albeit far less and more stable over time. So they don't have that same variability. Whereas women, obviously, when we go through menopause, we have this dramatic change in the amount of available estrogen. So that's one of the things that can play an important role. And then, hormonal balance around thyroid function and some of the genetic abnormalities that we can inherit that make us less efficient either at turning the common form of thyroid hormone that's made by the thyroid gland T4 into the more active form T3, and then whether or not we can transport that into the brain tissue, because there are specific transporter proteins that can be affected by genetics. Same if we go back to estrogen, there's a specific type of estrogen receptor gene defect that makes you more susceptible to cognitive decline. And those people respond even more to the replacement of estrogen in their system. So there's just a lot of things to be thinking about, both from the perspective of what are the genetics that this person inherited that have created vulnerabilities, and then what are the experiences, the deficiencies, the excesses, the things that haven't been done as well as we could have done in our lifestyle choices that have activated or kind of taken advantage of those, insufficiencies. And then that creates this environment where the brain has degeneration. Then moving into the cardiovascular health, this is, as you mentioned, this was my, kind of my first love into this world. But one of the things that we've learned a lot about in the last 20 years is something called the endothelial glycocalyx. And it's this, fine, almost, fibrous type layer that lines every blood vessel, every single blood vessel in the entire body. Well, in the brain microvessels, it's 2 to 4 times denser than it is in the rest of the body, because it plays a really critical role in what we all learn about as practitioners, the blood-brain barrier, right? This privileged, defined way that the body keeps things that are in the blood that the rest of the body is being exposed to and having to deal with, keeping those things from being able to enter the brain. So that endothelial glycocalyx is a really critical part of that blood-brain barrier function. And so paying attention to that, measuring markers that tell us that that's been damaged, and then looking just specifically at, is there inflammation in the lining of the blood vessels, and then what that potentially means. So a whole array of things beyond just cholesterol balance that have a really big impact on both vascular health and brain health. And then the other thing that I teach practitioners when we're doing our trainings is it's not a very effective outcome if you're putting all this effort into reversing somebody's cognitive decline and they have a vascular event like a heart attack or a stroke. So we need to be paying attention to those things, managing that risk, so that we aren't like paying attention to this over here, but not paying attention over here, or ignoring this and then having a bad outcome as a result of that. So that's kind of part of what I mean about how we need to be paying attention to so many different pieces. It's like a symphony, right? Like you have to, every different section of instruments plays an important role in how that symphony is going to sound. And so we have to be paying attention to each one of them. We can't just focus on the strings and hope that everything will be okay with everything else.
And,
So then
yeah.
after, yeah, go ahead.
No, go ahead. Continue.
Yeah. So I was just going to say then after vascular health, then we have the biome and the biotoxins.
Mhm.
So the microbiome, we've heard, we've learned so much about the microbes that we share our body with. And it's not just in our intestinal tract wall. That is probably arguably one of the most important, but it's also in our, in our nose and mouth and in other tissue interfaces. And there was a really interesting study that was done looking at the microbes that were in the brain at autopsy, just part of that environment, because we've always thought the brain was sterile, just like we thought so many other things were sterile. But really, the microbes are imbalanced, so there's not an infection. So we have this microbial community that occurs. And when you look at the difference between what someone who passed from something unrelated to brain degeneration has in their brain and what somebody who dies from Alzheimer's or Parkinson's disease, for example, they have very different microbial compositions within the brain. So that comes back to the oral microbiome and what's happening in the gums and gum disease and how much that impacts brain health. And then the biologic toxins are things really like mold. Mold produces toxins. We're all most familiar with penicillin as being discovered coming from, it's a mycotoxin that's produced by mold that's a very effective antibiotic. Well, there are hundreds, if not thousands, of mycotoxins that are produced. We know for sure of at least 300, probably more, because that was a couple years ago, the last time I looked that up. But these toxins are really, really poisonous within the human system. Some that we detect in people's bodies are even used in biological warfare as nerve agents or have been purified as other drugs. Like one mycophenolic acid has been purified into drugs that are used to prevent organ transplant rejection. So these are really powerfully acting chemicals within the body. And so that is one of the things that we have really learned, both in our own clinical practice and in the research studies, the first precision medicine pilot study that was published, and then also the randomized clinical trial that I'm one of the investigators in, is that we really see that people cannot have lasting improvement if that biotoxin load and the biotoxin environment and maybe the mold in their home, for example, isn't dealt with. So that's that section. And then the last section is chemical toxins. So heavy metals are one example of that, like mercury and lead, for example, or just the chemicals that we're exposed to in everyday life, from air pollution, from our water, from our cleaning supplies, our personal care products, just all of those chemicals make their way into the body. And whether you think of them as toxins or not, they're foreign chemicals that require energy for the body to get rid of it. And
Mhm.
so if we have a system that's compromised in its energy production, then it's going to be compromised in being able to get rid of those chemicals. Are going to linger longer. They may have more negative effects. So that's the overarching overview of what we need to be looking at.
Wow, that's amazing. I mean, that's so comprehensive and wonderful. I have so many questions, and I'm going to try and
Please.
just summarize it. So I think, just to recap, so the key factors are metabolism, hormones, cardiovascular and endothelial health, the gut microbiome, and obviously the oral microbiome, and then biotoxins such as mold, and then chemical toxins such as pesticides, heavy metals. So I think so that's six, if I've got that correct. And what you're saying is those are really the essential root causes, in some sense, of a process that then can trigger and then maintain neurodegeneration. And so, what is the process? I mean, obviously you can't touch on all of it, but for instance, I'm interested in the process of mold, for instance, which is a particular fascination of mine because I myself have been exposed to mold and had very bad neurological symptoms as a result and was completely blindsided by this. So you take mold. What is the process through which these biotoxins then can cause neurodegeneration? And I know that Del Bredesen, who you work with, calls mold inhalation Alzheimer's with good reason. So how does that actually work? What is the mechanism?
Well, we don't fully understand all of the mechanisms that are involved in that, but what we do, excuse me, what we do understand is that these mycotoxins as a class create an enormous amount of oxidative stress. And so that generates a demand from the body to try to quench those free radicals and change the way that those are damaging individual proteins or membranes or cellular structures. And so that's a big piece of how they create damage. But beyond that, specific mycotoxins have been found in the research to have some very specific effects. Some are more attracted to the neurologic tissue, like gliotoxin, for example, aptly named because it creates a lot of glial inflammation in the brain. We also see like the class, like the trichothecenes that tend to have a very significant impact on cognitive function, probably through those same mechanisms. We know some of them are carcinogenic or cancer promoting, and others, like what I mentioned earlier, mycophenolic acid, alter the immune system. So, if we even just take that last example, if you have a mycotoxin in the body that is in some ways suppressing the immune system function or altering the immune response, then that's going to change the way the body or the tissue within the brain can respond to things that maybe gain access through a damaged blood-brain barrier that shouldn't be there, but the immune system is incapable of dealing with it and helping to get rid of it. I mean, that's a simplification, but it's just conceptually what we think is happening. There is still so much to be learned. But really, to your point, my entry into the idea that you could make a difference in someone's cognitive health came through my work with mold. And the mold work came from some of the cardiovascular stuff because mold mycotoxins can dramatically affect the production of cholesterol and LDL. And we've seen in some people that addressing the mold in their house has resulted in as much as 100-point drop in LDL.
Wow.
So from an LDL of two in the 200s to one of 100, with really that being the main thing that we've intervened on. It doesn't always happen that way, which comes back to the nuance of our genetics and how the body responds and all of the different things, the burdens that that body is carrying. But it's really fascinating how tightly connected all of these various things are. So with the mold piece, there's really the two sides. One is the mold spores themselves, which traditionally is what conventional medicine has focused on in terms of that potentially stimulating allergies or sinus problems or things of that nature, true allergic reactions. And then we have the mycotoxin effects, the effects of the poisons, really. And so we have to help the body offload those toxins that have been accumulated and then potentially stored in the body. Because when we do that, that's when we see improvement. If we don't address that, we can see improvement from the lifestyle changes, and then we see the decline start to kick in again. Whereas when we address all of the pieces of the puzzle, we generally see improvement and then we can sustain that improvement.
So interesting. And you also talk about the endothelial cells and that sort of fibrous endothelial
Glycocalyx.
glycocalyx. It sounds like a sort of Roman something, but it's so what affects that? Because is the integrity of the endothelial glycocalyx what really makes the blood-brain barrier impermeable? And if that integrity is breached, does that then cause this blood-brain barrier permeability that then causes neuroinflammation?
Yes, so there have been few studies now that have been published that show that disruption of the endothelial glycocalyx does lead to increased blood-brain barrier permeability. It's not the only thing, but it is a very important piece because you also have tight junctions. And so in the same way that we have tight junctions in the gut that help to keep us from having leaky gut, we have the same we have the same types of tight junctions or similar mechanism of tight junctions in the brain. But with the endothelial glycocalyx, I'm so glad you asked this because some of the things that damage the EGX are so common and such low-hanging fruit. For example, high blood sugar is one of the most damaging things to the endothelial glycocalyx, which is really interesting when you think about the correlation between the increased risk that people with diabetes have for cardiovascular disease. Because while half of the average population dies from cardiovascular events, heart attack, stroke, sudden cardiac death, 2/3 of diabetics die from that. So there's a much higher incidence of these adverse cardiovascular events in the setting of chronic hyperglycemia. So that's really interesting because that's an easy thing for us to fix, right? Easy thing for us to fix. Then other lifestyle choices that create more oxidative stress or more inflammation, those will all also contribute to damage to the endothelial glycocalyx because they activate a class of enzymes called shedases that basically, how I explain it to patients is they're basically like a lawnmower. So those enzymes will just kind of lawnmower off the little fine hairs of the endothelial glycocalyx. And then when you don't have that protection, then that wall of the endothelium is a little stickier because that's supposed to be the nonstick layer. So, I mean, a great analogy for this, not that we want anybody using Teflon, but back when we used to use Teflon pans, when you would get a bare spot of the Teflon on the pan, that's where everything would stick. That's a perfect analogy to what happens in the EGX. Maybe I need to find a better one that's less toxic, but it works.
That's amazing. And so, and you talk about, the importance of really looking at the cardiovascular piece alongside the sort of, the endothelial piece, et cetera, which are very linked. I mean, there is a very high comorbidity, presumably, between cardiovascular and cognitive decline. And how much of it would you say? So if you look at blood pressure, blood sugar, the sort of integrity of the blood vessels and the whole cardiovascular system, how much would you say if you fix the cardiovascular piece, how much would that, and this is probably a silly question, but how much of that would really help the cognitive piece? More almost than anything else, would you say? Or is it just equally important?
Well, it's a really good question, and it's completely speculative at this time because we don't really know. Like, I know the group of us that are the 6 investigators in the randomized controlled trial, like we all have our opinions about what we think. We are all of the same opinion that mold seems to be a very heavy burden, that if that's not addressed, that we don't see improvement. I think with the cardiovascular piece, what intrigues me is if we're focusing on this, and this is something I observe in my practice because of the primary care side of our practice, where we're focusing so heavily on the cardiovascular risk prevention.
Exactly.
But if we're focusing on that up front, do we actually see a decreased incidence of cognitive decline? And of course, I do see that in my practice, but it's a little bit hard to draw conclusions from that. A, because it's just observational. B, because you're self-selecting for people who want to invest in a higher level of care for their health up front, right? So it's hard to tease all of that out. But intellectually, it does make sense that if we do the things that improve the body's protections for blood-brain barrier breach, for chronic inflammation, for chronic innate immune activation, all of these things, it just stands to reason that you would expect that you would see less cognitive decline as a result. And only time will tell, but that's,
Yeah.
of course, what our hypothesis is.
And the other thing you talk about is the hormones, the hormonal piece and the estrogen and you know that part of the brain being so rich in estrogen receptors. And I'm always very interested in the high number, the high concentration of cortisol receptors, for instance, in the hippocampus. And I'm fascinated by the impact of cortisol and sort of chronic stress on the brain. And so is that something you look at as well alongside the sex hormones is, you know, these stress hormones and you know the for instance the benefits also of oxytocin and countering cortisol and the you know the detrimental impacts of chronic stress both on cardiovascular health obviously but also on cognitive health. How do you incorporate that into your work?
Yeah, that's a great question. I think in that arena, we're really looking at, um, first, I think just giving people hope that that goes a long way, that there is the potential for us to make a difference. I hope that we get to the place where we can say that we can consistently always be able to make a difference in this disease. Sometimes we get much better results than other times, but also part of that is because there's the two hands to the clasp, right? If the patient's not willing to do the work that they need to do, and once they get to cognitive decline, it's so much work.
Yeah.
Like doing this work as prevention just makes so much more sense. But anyway, back to your question. A lot of what we're doing with the psychosocial pieces of the pillars of cognitive health are mindfulness practices. We know mindfulness practices not only can change the structure of the brain in studies that have been done looking at that, but it also changes the way our bodies experience stress and the impact that that stress chemistry has. The same with, we talked about heart rate variability and heart rate variability training and improving the resilience to stress and then community and connection, that having community and a support network and things that bring passion to your life, that those things also have a very powerful impact, not only on the cortisol levels, the structural integrity of the brain, but just that whole piece of how those dominoes start to fall, because it's all intertwined.
It's all intertwined.
All
And
intertwined.
and then in terms of the metabolic piece, you know, I know that a lot of, I think your research is based on the ketogenic diet, if I'm not mistaken. In your practice, in your clinical practice, how easy and how effective do you feel it is? And do you actually advocate for a ketogenic diet in your patients? Or is it not a one size fits all? It depends on the patient. And how do you make those decisions as to which patients gets the keto? Do you think the keto diet is the best diet for cognitive health? And, it's not the easiest necessarily to implement. Is it a long-term diet that we should all be practicing in order to prevent cognitive decline? What's your view on that?
Yeah, those are really great questions. So I think first of all, the diet, the dietary intervention that has the most data overall is the Mediterranean diet.
Yeah.
And so I think when we're looking on the preventative side, I think following more of a Mediterranean diet, maybe a little lighter on grains than the Mediterranean diet typically is, especially in our country, because the grains have a lot of other chemical contaminants in them. But I think from a prevention standpoint, an anti-inflammatory focused, high in plants, lots of colorful fruits and vegetables, all those plant polyphenols and antioxidants, that's really probably our best protective approach. I think once people have cognitive decline, it's a different world. Now we're looking at diet as a therapy and
Mm.
as a therapeutic intervention. And for that, it does look like the ketogenic diet is one of the most powerful interventions, not only because it quickly changes the blood sugar environment, but also because it creates this alternate source of fuel, the ketones, for the brain to be able to use, and the brain is efficient at using ketones as a fuel. And then the ketones themselves also seem to initiate anti-inflammatory communication patterns within the brain. And so, for those reasons, the ketogenic diet does appear to be one of the more important interventions. Now, that being said, Dr. Dean Ornish just published last year in June his study, which is a completely different dietary approach, right? It's vegetarian, it's very low fat, as opposed to the ketogenic, which is not vegetarian, although we do try to make it very plant heavy. And obviously very high in fat, 70% fat is the goal. So both of these dietary interventions have been able to show in the precision medicine pilot study and then in Dr. Ornish's study a significant improvement in cognitive decline. So right, we don't know. We don't know yet which it is. I mean, it looks, if you just compare those two studies that have been published, that have been prospective, there was a little bit greater improvement in the people on the ketogenic diet than there was in the people that were on the low-fat vegetarian diet. But it does go to argue that the diet alone isn't the key.
Yeah.
But our belief is that this is a very important therapeutic diet. It is very challenging to maintain. It's not something that I typically have people stay on indefinitely, but while we're trying to reverse their cognitive decline, it is definitely our focus. And then after we get them improved back to normal, ideally, then that's when we may cycle them off of keto, or we may do a diet that isn't necessarily ketogenic, but is more akin to what I was describing, like a high nutrient density, kind of more of a mitochondrial food plan, like really focusing on the things that are supportive of that energy generation and very low in glycemic load.
It's very tricky, isn't it? This whole, this whole debate between the plant-based and the keto. And I was fascinated to see Dean's work, in fact, and he's speaking at IPM Congress in London here in a month, in fact. Um, and he's presenting his data, in fact, in the Mental Health Day, which I'm co-chairing. But I'm really looking forward to seeing that because I'm a little skeptical about you hear so much about the benefits of the ketogenic diet and the Mediterranean diet, but mainly the keto diet, and you just think, how can a low fat
Yeah.
diet achieve the same things? And I'd be interested in looking at the details and the numbers, etc. But that'll be very interesting.
Well, I
And
think,
yeah,
if you don't mind, I
yeah,
think, to this point, part of it is just the change from the highly
yeah.
pro-inflammatory standard American diet, for example, since both of those studies were done in the US, right? Like just getting people away from that very highly pro-inflammatory diet, that alone
Mm.
creates a benefit. I think the longer term observational studies where we really see how it plays out in the long run, that'll give us more information about maybe which approach may have either a greater delta or more of a long-term benefit. Obviously, I have my bias based on what I use, but I think we'll learn more about that.
Yeah, I mean that I think you're right, but also I'm curious, when you select the participants, are they people who are eating a sort of sad diet, a standard American diet, and then you change them, or are they people who are relatively healthy who then and I think the other question to look at is, what are the other elements? Because I know in your study with Dr. Bredesen, you look at all these different elements. Diet is just one of them, and you dial up all the toxins and the hormones and the exercise, etc., and the light therapy, and I think those are really key pieces, and I'm curious as to whether Dr. Ornish, takes into account anything else. And the other thing you mentioned also is these stealth infections, which I find fascinating. And I think I read somewhere that something like 98% of autopsied patients who had Alzheimer's had herpes simplex 1, for instance. I think there was some sort of statistic about that. And infections, we're learning more and more, are absolutely key to this cognitive health. And how much do you take that into account? What can we do about them? How can we diagnose them? How can we treat them? And I mean, some people might have these infections for a long, long time and not know about them, and maybe they don't do anything. But in other people, they sort of trigger an inflammatory reaction, which is chronic. What is the difference? Is it an immune system response difference? Is it, and how important are these infections, do you think, in cognitive health?
Yeah, again, excellent line of questioning. None of those answers exist.
Yeah.
I think that, part of it is just changing the paradigm of our understanding that the brain is not a sterile environment. Part of it is then understanding at what point does the normal load of microbes, be those viruses or bacteria like intracellular bacterial infection. Another study showed 90% of patients with Alzheimer's had Porphyromonas gingivalis in their brain. That's a gum disease bacterium. And so, and then these viruses, we know many viruses that enter the body never leave. They're just present and in a latent form, not actively replicating. But is it the changes in the immune system that then the environment becomes permissive for the virus to be able to replicate, and then that creates more inflammation that stimulates the degenerative process? Like there's a lot of potential explanations for why these are important. And to your point, is it just the presence of the microbes that's the problem? Or is it the presence of the microbes and the loss of the immune surveillance that keeps them in check? Is it some combination? Is it the load, right? Like these are all questions that we don't know the answer to yet. We do address stealth infections in the study, but to what extent those and the amount of incremental difference that's making, we just don't know the answer to that yet because the research is still so young. We're really just at the point of even proving that this is possible. And then the hundreds of studies that'll be required to tease out the nuance of all of these different components and what actually creates more impact and then what maybe doesn't create as much impact as maybe we believe that it does. And that's one of the things that we're also hoping with TruNeura is that we're asking people permission for their data to be included in a registry so that we can start to mine that information anonymously, obviously, but to start to understand, like, do we see separation of groups of people based on how much improvement we've seen in these different areas of markers? And that I'm hoping will help us to start to get a picture of where do we really need to put our attention, because right now it's a lot for patients to do. It's a lot for families to support them in. It's expensive. It's really hard. I mean, your choices, otherwise this fatal disease takes you. So it's just not a great place to be at all. But it would be nice if it could be a little less hard.
Yeah, no, I agree. And I think your work with TruNeura really tries to accomplish that and make it less hard, both for practitioners and patients. It's just a lot of information to juggle and to implement. One also question, obviously, my interest is particularly in mental health, which there are two sides to that. One is neurological health, which is what we're doing, what we're talking about here, but also psychiatric health, and the sort of psychology, the psychospiritual, and the mood disorders, the anxiety, etc., that often go along hand in hand with neurological issues. And have you found in your practice and in your research as well that when you dial up all these different factors from a biochemical point of view, the psychospiritual sort of contributors or symptoms improve? have you noticed in terms of mental health that, when you look at the biochemistry and you try and regulate the metabolism and the hormones and the gut and the toxins, etc., that there's an impact on mental health more from a psychological point of view?
Yes, absolutely. I mean, we're not looking at that specifically as an outcome measure, but just in general, like people will say that they feel significantly less anxious, that they have a greater sense of well-being. So a common thing that we hear is, I feel like myself again.
Mm.
Yeah, which is wonderful. And definitely improvement in depression is often seen in particular as we improve the gut microbiome environment, which
Yeah.
is really interesting. So yes, all of these same things that create neurodegeneration are the same types of neuroinflammatory patterns that can lead to psychiatric symptoms. So it is really fascinating how much more potential control that we might have over some of the psychiatric illnesses that are so difficult to manage for clinicians and for patients, and where the medications can be really, really laden with side effects. So the
Especially, yeah,
yeah.
for the mitochondria, it always makes me, the effect of SSRIs on the mitochondria is which can be very detrimental, is really not great because you really want your mitochondria to be working well in your brain. And then the other thing is, if you look at other neurodegenerative concerns such as Parkinson's, for instance, I mean, we know that air pollution is hugely correlated to an increase in Parkinson's. And, would you say that the same mechanisms or similar mechanisms that affect Alzheimer's also affect Parkinson's? Is it the same mechanisms across the board in terms of neurodegeneration, whether it's ALS or Parkinson's or Alzheimer's, or are they all slightly different?
Yeah, it's a really interesting thing to ponder. I'm not aware of us as a scientific community having a very clear sense of the exact mechanisms that we end up at each of these places. However, like in Parkinson's, for example, we know now that the alpha synuclein the tangles that can be found are first found in the enteric nerves in the gut, so the nerves in the gut, and that is then presumably transferred or transmitted up into the brain. But why specifically we see degeneration in the substantia nigra in Parkinson's disease, for example, as opposed to the hippocampus in Alzheimer's disease, right? Like I don't know that we really know the specifics of that.
Yeah.
But that being said, there are so many commonalities in terms of, right? So the Parkinson's example right there, like we know that the gut microbiome environment, gut inflammation, leaky gut, the inflammatory cascade, the enteric nervous system, all of that is involved in Alzheimer's degenerative disease. It's involved in Parkinson's degenerative disease. Is there some genetic component that makes that part of the brain the weak link for that person? Is there a combination of exposures that maybe lean itself that way? I'm not sure of what those answers are, but we're getting closer and closer to understanding them. There was another interesting study. You mentioned ALS that was done quite a few years ago now, and they found in like 14 of 15 ALS patients, they found the presence of this parasite called Perkinsus, which is a muscle wasting parasite in oysters.
Wow.
So that was fascinating. So, right, like there's all these really intriguing individual findings that, make us wonder, like how does it end up at that specific place? And then the same is true on the other side, right? Like the argument to be had over, can we have the same impact on reversing those other neurodegenerative diseases with these same types of interventions? And as yet, there's a little bit of a yes and no. If we can see improvement in some of them, we can see there is an effect of these types of treatments, but I haven't yet seen the same success in, let's say, Parkinson's, for example, that we can see in Alzheimer's.
Yeah, which
And
is
the question
interesting.
is why, right? Yeah.
Yeah, which is interesting. I mean, the question is why. And I mean, part of me wonders, yeah, I mean, also, is it a question of how much it's been studied? I mean, there haven't been the same precision trials, as far as I know, on Parkinson's as there have been on Alzheimer's. And maybe if we were to use these precision medicine studies, as you guys are doing with Dr. Bredesen, for the Parkinson's community, would they show similar effects?
Mm-hmm.
I don't know.
Yeah.
And so just, I mean, you've been very generous with your time, so we will be wrapping up soon. But I am fascinated with your approach, both as a clinician, so working with patients, and also as a researcher. And I think your work with the research and, in crunching numbers, gathering data, analyzing the data, and then your work with patients as a clinician has really led to this creation of this TruNeura platform to help both the patients and the clinicians. Can you tell me, in your practice, on a daily basis, how your patients sort of, you'd mentioned that none of them had had a heart attack for 12 years, but do you see that compared to when you used to practice medicine before this era of precision medicine, that there's been a huge difference in terms of how the patient outcomes, first of all? Second of all, are you using this TruNeura platform for your patients at the moment in cognitive decline? Are you planning to roll it out in other areas? And how are you working with your patients to get them to look at these root causes and then implement these sort of multifactorial systems approach to their health? So I guess I'm asking, from a clinical perspective, what are the tools that you're using and the platforms that you're using to actually implement this type of systems approach? Is it working? And what have you found to be the most effective in improving your patient outcomes?
Yeah. So, yes, and that is one of the first questions that practitioners ask when they're seeing TruNeura for the first time is, can I use this in my other patients too? Because
Right.
it is the same, conceptually, many of the same things. And yes, our intent is, this is the most pressing need with the least amount of practitioner capacity. And so, since in my mind, this is kind of the hardest work that I do, I thought if we started TruNeura with cognitive health, that it will be much easier to then add, kind of a cardiovascular focus, which in large part we do already have that here, but maybe to just have it pointed out more, and autoimmunity and different arenas where we might want to focus our clinical attention. So yes, that is definitely the goal, is to improve the efficiency of functional and precision medicine overall so that this can be the way medicine is practiced. Because now, having done this for over 15 years, I am so solidly convicted that this is the way that primary care should be practiced, and that the entire concept of waiting for disease to develop before we do any intervention is literally insanity to me, now that I see the impact that you can have when you just pay attention to different things. But that's my little soapbox there. I think in our clinical practice, because about half of our practice is, day-to-day primary care with our patients. And I hate to even use the terminology primary care, because how we approach things, everything is approached from a systems biology and a root cause perspective. So I need to come up with a new term, because when you say that, people think about conventional primary care, and this is so different from that. But nonetheless, that is half of our practice. And then the other half is our consultative, our complex chronic disease unraveling. And then within that, we have our memory protection program. And so in our other disease states that maybe we're working with, like I said, like autoimmunity, or maybe somebody who's just coming to us for, they've had a heart attack, they want to reduce their risk of having another one. We definitely do more of a tone down and a bit more stepwise, like what you were alluding to earlier in our conversation, like kind of starting with, these lifestyle changes. And, we need to make sure that you don't have a high mercury burden, because mercury, we know, is so vascular toxic, and make sure that the vascular inflammatory markers are controlled and that the endothelial glycocalyx is healthy, like a little bit of a different focus. And then we kind of start weeding our way or digging our way into some of the other arenas. And then in autoimmunity, we'd probably be a bit more focused on the gut environment and making sure that we've resolved leaky gut and the contributors to that, and then calming the immune system and trying to create rebalance in the immune system. But all of those things are things that we're doing in every arena, just maybe a little bit more heavily upfront in some conditions than others, where we don't have a brain at stake and imminently a life at stake.
Yeah.
So like we do in dementia. I think that answers
Yeah, no,
that
that totally
question.
answers it. And I guess, you said something interesting, which was that it was, the reason you started with your cognitive work was because it was the most complex and the most pressing in some ways. And I was just curious about that. I guess because, to your point, there's less time to play with. Like there's less luxury of time because it's going so quickly, right? So, yeah.
Exactly right.
Yeah.
Exactly right. And then also because I've observed in many colleagues that got training in this type of work, 6 or 8 years ago, that they're not doing it anymore because it was too hard. It was too complicated to try to implement within their practice. It required more support than they were able to do, which was also in part why, TruNeura is there to really help augment the health coach, the health coaching role, to create the tracking so that when the health coach has time with the patient, they can really be focusing on, okay, so I see what you've accomplished. I see where you're struggling. Like, let's tackle those barriers so that we can really incrementally move things forward. It's in no way intended to replace either the clinician, the medical practitioner, or the health coach or dietitian, but augmenting. That's really where I see AI taking us. I don't see AI as replacing medical practitioners, but I see it as dramatically augmenting our effectiveness. And that's what I really want to accomplish. If this can help us to accelerate not only the outcomes that we can get with patients, but the number of practitioners who have the capacity to do this type of work. We're looking at the statistics for the population change in terms of dementia is supposed to triple by 2060.
Wow.
Yeah.
Wow.
Yeah. And it's a 40% increase by just 2030. So we're one and a halfing, and then we're doubling, and then we're threefolding. Like the need for this type of medicine, not only to help the patients and the families and right, like from the human side, but just looking at it from a fiscal perspective, it's estimated to be somewhere between 9 and 15 trillion that it'll cost worldwide for dementia care by 2050, 2060, if we
Wow.
don't do something different. And right now it's somewhere around 3 to 5 trillion. So like this literally could bankrupt every country's healthcare system if we don't do something differently.
And can I ask you very quickly, what do you think is driving that increase? I mean, I know that you mentioned, there's sort of this perfect storm between our processed foods, our stressful environments, the pollution and the toxins. But what do you think is driving this exponential growth in sort of neurodegeneration?
That's such an excellent question, and I have a number of hypotheses rattling around in my head as to why I think that might be. We don't know, but why I think that might be. even if we just look at it from the subsets of root cause perspective, we have this massive explosion of obesity and metabolic dysfunction and diabetes.
Yeah.
And we know how each of those things can impact brain degeneration, neurodegeneration. We also have had this big shift in our food towards like you said, the processed foods and lack of nutrient density within the food that people are eating. And so we see there was a study published. I'm going to tell you what we see is that literally every patient has multiple nutrient deficiencies, sometimes just insufficiencies. But there was a study published where I think, if I'm quoting it correctly, 80% of patients diagnosed with Alzheimer's had at least one nutrient deficiency, like a true deficiency. So we have that piece of the puzzle. Also, another fascinating one that I have rattling around in there is this generation of people went through adulthood during the low fat craze.
Mm.
And with that, we tossed out one of the few sources, natural sources of pentadecanoic acid, which is an essential fatty acid that's involved in cell membrane fragility and flexibility, activating anti-inflammatory, antioxidative stress, pro cell renewal pathways, like really important pathways. And so we have this massive population-wide deficiency that we've developed as a result of limiting the dietary source of that essential fatty acid, just as one example. And
What
then
is
we
that
have
dietary source? Before you move on, what is the dietary
it,
source?
it's full fat dairy.
Full fat
It's
dairy.
full fat, yeah, full fat dairy. And then you have the problem of, well, in my mind, it should only be organic full fat dairy. And then when you look at grass-fed organic full fat dairy, that's the healthiest version of it. So it's not, that's the other problem that you run into when you're just talking about a large food group, is there's so much nuance behind it. I think a lot of that plays into some of the studies around meat and red meat. Is it really the red meat, like literally the thing that we evolutionarily have eaten for thousands of years? Or is it our conventional farming practices of red meat and what inflammatory fats and the inflammatory signal messengers that end up in that meat that then we're consuming, right? Just food for thought. And then, another interesting thing is we've seen, like you said, we've seen this kind of an explosion of mold-related illness. And I don't know that it's so much of an awareness as it is that it really does seem like more people are chronically ill in that way. Probably, again, multifactorial, but there was an interesting, thought-provoking thing said at a conference where they had taken mold grown in a petri dish, and one set of the mold plates was grown in the normal environment exposed to Wi-Fi, and one set of those plates was in a Faraday cage, so completely protected from Wi-Fi. And under the influence of Wi-Fi, the molds made 400 times more mycotoxins. So in the last 20 years, right, we've gone from Wi-Fi being a relatively rare thing that we were exposed to literally being exposed to Wi-Fi for most of us 24/7 in our homes, in our cars, in our work environments, like literally everywhere. So is the Wi-Fi increasing the potential biologic toxicity of the mold? And so it isn't so much that we have more mold now as that mold makes us more sick. I don't know. It's an interesting, it's really interesting thing to think about.
Well, it is. And also, there's the building materials, which are more
Yes,
flimsy, which are more prone to mold. I think there's the stress and maybe our immune systems are more compromised because
absolutely.
of our foods and the other toxins, etc. And, there, as you say, it's very multifactorial, but it is fascinating. Yeah.
It is really fascinating when you think, and all of those things, each of those potential individual explanations are also all interconnected to each other, right? They
Completely.
all create a vulnerability that then the next thing can, take advantage of, or yeah, it's really
Completely.
fast.
And so just to come back to TruNeura, so you train practitioners on how to use TruNeura, and you train practitioners essentially to be able to manage patients with cognitive decline or MCI. And so how does that work? Like if practitioners wanted to find you, what's the best way to do that? And presumably TruNeura only goes via practitioners. As a patient, you would experience it, but you would not be a candidate for any sort of training or purchase of it. Yeah.
Yes. This is entirely practitioner I mean, the company, the software is practitioner focused
Yeah.
because like I said earlier, I had all these colleagues who were doing excellent work who then decided that it just was too difficult to manage in their practice. And that was the thing that I wanted to change. So TruNeura.com is our website, TruNeura.com. And you could schedule a demo if you wanted to actually see the software and run through how it works, how it might help. It has there's a patient-facing app that's available in the App Store. You can actually download the app and just play around with that side. You don't get the full complement without having the practitioner obviously involved. That's where all of the laboratory organization and then the integration of the wearable information and the lab information happens together. And then, I'm hoping that as we get more and more practitioners, initially only available in the US, but we have hopes of bringing this worldwide as soon as we can.
Yeah.
I'm hoping that we not only learn from each other, but we can help to refine and identify the areas where we can have the greatest impact.
Yeah, because I mean, it's not just a tool to help practitioners and patients, it's also a data gathering tool to then analyze the data and do research, primary research into what works, what doesn't work as well, etc. So it's fantastic. And also you're going to be at IMMH, the Integrative Medicine for Mental Health in San Diego in September from the 11th to the 14th. We're really excited about having you there. And we're really excited about this because, it's so, as you say, the numbers are staggering. I, as a patient of functional medicine, am always overwhelmed by the amount of data. And I think, how do people who are in any way cognitively impaired deal with all this? My mother had Alzheimer's, and that was one of the hardest things to witness because over 5 years, she really declined until she died. And it was impossible by the time she had symptoms to get her really to implement any of the changes that really were instrumental to helping her. So I think something like this would have been just hugely helpful. So really well done to you for bringing this to the world. And keep up the amazing work. And I can't wait to see you at IMMH. And I really feel that this is something that should eventually be rolled out across the board to all sorts of other, other diseases, other problems, whether it's cardiovascular, whether it's autoimmune, etc. But there's so much potential, I think, in what you've developed. And so thank you so much, Dr. Kristine Burke. I really, really appreciate your time and your work.
Thank you so much. Well, I appreciate your time and your work and the amazing opportunity to get this word out.
Thank you so much for listening to the MindHealth360 Show. I hope that we've helped you realize that mental health symptoms have root causes that can and need to be addressed in order to sustainably heal, and have given you some ideas about steps you, your loved ones, or clients may take to start their healing journey. Please share this interview with anyone you think may find it helpful, and don't forget to subscribe to keep up to date with our latest interviews on integrative mental health. If you want further information, please go to www.mindhealth360.com or find us on social media. This information is for educational purposes only and is not intended to diagnose or treat any disease or to replace medical advice. Please always consult your healthcare practitioner before discontinuing any medication or implementing any changes in your diet, lifestyle, or supplement program.